Good morning. This morning we're going to be talking about musculoskeletal disorders, chapter 20 in the pediatric nursing book. Musculoskeletal is really hard, so lots of deaths today. We're going to be talking about the anatomy and physiology of the musculoskeletal system, common disorders, assessment skills, diagnostic tests and lab values, nursing interventions, hospital interventions, home interventions, so lots and lots of different things. So back to the basics, anatomy and physiology. So the musculoskeletal system is composed of your bones, your muscles, joints, tendons, and ligaments that interconnect. Muscle contraction is innervated by the somatic nervous system. Remember that fetal development of the musculoskeletal system begins with the formation of pure cartilage, which is then transformed by osteoclasts and osteoblast formation. The rapid formation of skeletal structures makes abnormalities somewhat common. And so when we think about those abnormalities, remember your environment, genetics, trauma. Your bones are cartilaginous structures that develop when kids are growing and developing. Growth plates are open in kids. That's especially important to remember, especially as we talk about fractures. It can make certain diagnoses more difficult due to age-specific qualities of bone and joint structures. Once maturation occurs, bones are characteristic dense osseous structures. As a general rule of thumb, kids' skin, muscles, and ligaments protect the maturing bones. That way that those parts are if those parts are weakened or not developed, the bones do suffer, which is important to remember. Anatomy of the growing bone, we have the epiphysis, which are the ends of the long bones. Excuse me. We have the physis, which is the segment of bone responsible for lengthening during growth. We have the metaphysis, which is the wide part of the long bones where the diaphysis and the epiphysis meet. The diaphysis forms from the primary center of ossification, sometimes also known as the shaft. The periosteum is a sheath covering the bones. One of the big things to remember on the physis is injury to the physis can cause long-term impact of a child's physical development. You got to remember that child's bones are different from adult bones. Adult fractures must be aligned perfectly, whereas children with open growth plates will remodel or form new bone to repair the fractured area. The younger the child, the better remodeling will occur depending on the extent of the deformity. But injuries that do occur after the kid is about 16 years of age will not have enough time to remodel completely. So risk for physeal arrest with subsequent growth disturbances present. This is also one of the reasons why your infants, their bones are more bendable. That sounds terrible, but if you have an infant with a fracture, it typically is something major, whether it's abuse or trauma, because they just have, their bones were more flexible because they're not as dense. Skeleton, kids have the immature skeleton, which is increased resiliency to stress. Thicker periosteum, increased potential to remodel, which is amazing that they're able to do that. Shorter healing times, presence of the physis, injury pattern in growing bones. And again, bones tend to bow rather than break. You can see a compressive force, which is a torus fracture or buckle fracture. And we'll talk about that more when we get it in the fracture segment. Ligaments and tendons are stronger than the young bone. Bone is more likely to be injured than soft tissue. The periosteum, which is that sheath covering the bone, is active in kids. This means that the periosteum is developing new bone and is also supplying blood. Kids tend to heal their fractures faster than adults. And so the big advantage to this is the immobilization times are shorter, but the disadvantage means that misaligned fragments become solid sooner. You need to anticipate bone remodeling, which is the absorption of bone tissue when new bone is simultaneously deposited, if the child has more than 2 years of growth left. Mild angulation deformities, less than about 2 millimeters, often correct themselves. Rotational deformities, such as those that are twisted, require reduction or placement of correct alignment because these will not remodel. Fractures in kids may stimulate longitudinal bone growth, and some degree of bone overlap is acceptable and may even be helpful. Children do not tend to get as stiff as adults after immobilization, yet they still need to regain strength after immobilization in 1 to 3 weeks of slow return to full activities once the pain, the swelling, the stiffness have resolved. So don't immediately educate them to just go right back into full activity. They do need to build up to it. After casting, a callus is formed but still may be fibrous. A provisional callus is temporary and still developing new bone. A definitive callus forms permanent osseous or bone tissue after several weeks. Kids should avoid contact activity for 2 to 4 weeks once they're out of cast. So start them slow and get them back involved, but those contact activities like football, something that's going to be actual contact, they need to avoid. So the evaluation tools that we're going to use all require understanding of the anatomy. The overall assessment involves simple to complex physical tests to evaluate themselves. We want to do inspection, palpation, range of motion, lab tests if indicated, x-rays, CT, MRIs, arthrograms, and the lab. There is a great chart in your book that kind of talks about the CBC, because remember you want to check for anemia, clotting disorders, a CRP, the SED rate, which all kind of looks at inflammation, rheumatoid factor. Remember their calcium and their phosphate levels can indicate how their skeletal system is, and then aspiration. If you have somebody that you're aspirating a joint, you always send that in for pathology. Understanding normal motor development and screening tools also help determine problems or potential delays. Remember, the motor development is a child's increasing ability to move and interact with the environment. And we, make sure, remember, as we talked about that growth and development, that the rate does vary among individuals as long as it follows a predictable pattern. You do have to remember that some, kids, due to congenital malformations, that they may be behind. So you really do want to take a thorough history, a birth history, the degree of prenatal and postnatal care to incorporate all of that into your plan of care. When you're doing your general assessment, you're going to do that physical examination. And what's great about the skeletal system, especially when you're talking about the extremities, you always have one to compare. So if they have a hurt wrist, compare it to the other wrist. Is it more swollen? Is there decreased range of motion? But that's what's really nice, is you can compare it. But you're going to do your physical examination, history taking, height and weight, any diagnostic imaging if it's ordered, any lab testing if it's ordered, motor develop evaluation, and then of course family expectations. When we talk about emergent care or initial nursing care, remember PRICE, P-R-I-C-E, and that's kind of new. When I was in school, we always remembered RICE, R-I-C-E, but it's actually, they've added a P to it, to PRICE. So you have protect, rest, ice, compress, and elevate. and that's with any new injury. You're going to perform neurovascular checks, and if it's something that requires surgery or casting, you're going to continue to do those. Natural alignment is best to prevent deformity, and it improves function. If they're splinted, cast, or braced, you're going to make sure that that stays intact, and reinforcement of any bandages or splints is needed. You're going to monitor their weight-bearing status. You're going to teach and monitor the use of assisted aids as needed. And remember, you're going to also teach this to the family. Activity levels, as indicated, you're going to give all pain medication as ordered. And you're going to really watch for the side effects and how much they're using it. And remember, as we talked about the pain medications, you need to do an appropriate pain assessment. And that may be different on the child based on the developmental age, based on the cognitive age. And you're going to educate both the patient and the family on non-pharmacological methods, especially distraction is particularly helpful in this situation. But you can use any of them. Problems or concerns that require immediate medical attention are slip bandages or splints, high fever, foul odor from the bandage or splint. You're going to want to make sure and provide support for post-op coping and family support or community resources for the family. You're going to get the interdisciplinary team involved, and this should include social work and rehab services. You're going to want to make sure the patient and their family understands school and gym class as well as sports participation restrictions. And you may need to be educating them on toileting and other activities of daily living depending on where the cast or splint is or surgery, and of course educate them on the follow-up visits. Fractures in kiddos are more complicated than adults due to the nature of maturing bones, the cartilage features, and open growth plates. So we have the torus fracture, and that's your buckle fracture, and those are some of the most common among kids. I see those a lot, actually. The mechanism of injury is usually a direct fall onto an outstretched hand. So remember, they're falling down. Let me get in front of the camera, and they're hitting that hand. But it basically compresses that bone. And so sometimes buckle or torus fractures, you can remember the acronym FOSH, F-O-O-S-H, fall onto outstretched hand. F-O-O-S-H is your buckle fracture. Fall onto outstretched hand. Occult fractures are common due to the maturation process. An occult fracture of the tibia is called a toddler's fracture. An occult fracture is rarely seen on emergent x-rays, but the child may cry or refuse to weight bear on the affected extremity. Remember, if you have an x-ray of an acute injury and it doesn't show anything, but the kid or adult even is not getting better, you do need to re-x-ray that in a week or two just to make sure that there wasn't a fracture that shows up then. So we typically use walking boots or casts in the lower extremities, and upper extremities or braces or slings, but sometimes that's the most common, but we sometimes do other things. You do want to repeat the x-rays in 3 to 4 weeks to know if they are getting a callus formation along the seam. So basically when they have the fracture, like this is the fracture, you'll start seeing this little callus formation over the top of it. It's super cool. I encourage you to look it up online under images, because you can always tell if there's a fracture that's healing. Excuse me. So, educating patients on after an injury is no running, jumping, climbing with splints or casts, No activities with balls or bicycles. Do not insert food, toys, or other objects into them. Think about your kiddo that has the arm cast and it's itching, so they want to stick stuff down in there to scratch. Don't do that because they can really cause damage to the area. They can scrape it and it can get infected. No slings around the neck to the bud, and slings, because remember, you don't want it to get wrapped around their neck as they're sleeping. Slings should be at heart level. Lower extremities, you're going to use braces, crutches, so you need to teach them how to walk with crutches. You need to involve the patient's family in that education. Wheelchair, stroller, as it's indicated. And you may need to get a physical therapist involved to determine exactly what they need. Physical injuries, many childhood fractures does involve these, and about 27%. But it can disrupt growth of the bone, and injury is near but not at the physis can stimulate bone growth. Most commonly involved sites are your distal radius, right here. And a lot of times you can fracture that wrist along with some of your metacarpal and your phalanges. And that accounts for about 50% of injuries in kids. Clavicle fractures, hand, elbow, radius, tibia. But again, they're going to be classified as some of the pictures below that we've already talked about. Green stick, the buccal or torus fracture, remember Foch, and plastic deformation fractures. We can have simple fractures, which just heal up. We can have comminuted fractures, complex fractures, physical fractures, as classified by the Salter-Harris 1 through 4 based on the level of the growth plate involvement. That system, the 1 through 4, delineates risk for growth disturbance from the fracture. High-grade fractures are more likely to cause growth disturbance, but it can happen with any of the physical injuries. But a type 1, the fracture passes transversely through the physis, separating the epiphysis from the metaphysis. The type 2 fracture passes transversely through the epiphysis, but exits through the metaphysis. Triangular fragment. Type 3 fracture crosses the epiphysis and exits through the epiphysis at the joint space. Type 4 fracture extends up from the joint line through the epiphysis and out of the epiphysis. And type 5 is a crush injury to the growth plate, which is bad. Again, that torus fracture, the bone bends and buckles, Foch, but doesn't break it. It occurs commonly in the radius or ulna. It only occurs in kids because their bones are softer than adults. Many torus fractures are not diagnosed until days after the injury occurs. Treatment strives to alleviate the pain and prevent further deformity. No reduction is typically needed, and typically kids will wear a short arm cast for 3 to 4 weeks. If the injury is more than 24 hours old, it will be casted immediately. However, newer injuries are splinted for about 5 to 7 days before casting. And again, that's to let everything, all the swelling, to get out of there and see where everything is going to end up. Green stick fractures are incomplete fractures along bones that are commonly mid-diaphyseal. If it's non-displaced, this injury is typically treated with a short arm cast for about 4 weeks, and then a removable splint for about 2 weeks after that. If the fracture is displaced more than 15 degrees, it is reduced and immobilized in a long arm cast. Distal radial fracture. This is a common bone fracture that affects the radius in the forearm. Because of its proximity to the wrist joint, the injury is often called a wrist fracture. When displaced, the fracture should be reduced as soon as possible. A non-displaced is a short arm cast for 3 to 6 weeks. And if you don't know what that means, it's just like it sounds. A displaced fracture is where the bones do not line up, and it can be little. I can't do it really good. It can be just a little, or maybe it's like that, or maybe it's on top of each other. But A non-displaced fracture is where the bones are lined up. The older that the kid is when the injury occurs, the longer that they are immobilized. The child typically has tenderness over the growth plate, and the wrist should be immobilized and then re-x-rayed to determine how they heal. Elbow fractures are about 10 to 12% of pediatric fractures, and most are supracondylar fractures. Elbow fractures in kids are complex to diagnose and as well as manage. Think how much you move that elbow. And they have lots of immature bones, and it's also involving a lot of bones. You know, you have your humerus, your radial, your ulna, so lots of things there. Early recognition and referral will provide the best outcomes. You have supracondylar fractures, and that affects the weakest part of the elbow joint where the humerus flattens and flares. Peak incidence is about 5 to 7 years old, and it does represent 60 to 80% of pediatric elbow fractures. Most commonly, extension fracture is characterized by elbow pain and swelling. There is a potential for vascular compromise. Remember, when you're doing an assessment on these kids, you need to do the 5 Ps: pain, pulse, pallor, paresthesia, and paralysis. You need to know those 5 Ps for your exam as well as the NCLEX as well as your practice afterwards. Pain, pulse, pallor, paresthesia, paralysis. Put those on a note card, memorize those because those are all super important. If a pulse is compromised, a fracture needs reduced immediately. You do need to check that nerve function in the hand. Most supracondylar fractures are displaced and do need surgery. Non-displaced fractures can be managed with a long arm cast where the forearm is neutral and the elbow is at 90 degrees for 3 weeks. Follow-up x-rays are taken 3 to 7 days later to document alignment, and then x-rays are taken at 3 weeks to document that callus formation. Once the callus is noted at 3 weeks, the cast can be removed, the pins are pulled out in the office, and they start active range of motion slowly over the next 1 to 2 weeks. If no range of motion improves in 2 to 3 weeks, they need to be rechecked in the office and sent to occupational therapy. Lateral condylar fractures is the second most common elbow fracture. And again, it is a foosh, fall on outstretched hand, plus a varus force. So foosh plus varus force, and it causes a lateral condyle avulsion. On examination, you're going to see a focal swelling at the lateral distal humerus, and most are displaced and most require surgical pinning. If it's non-displaced, though, you can treat with casting a posterior splint with the elbow at 90 degrees, and they need weekly follow-ups to check for late displacement. If they're stable at 2 weeks, then they continue their long arm cast for another 4. Complications can be their growth can stop, as well as non-union of the bones. A medial condyle fracture is the third most common elbow fracture. It's very common among baseball pitchers between the ages of 9 and 14. It's an overuse injury caused by repetitive motion and increased muscle fatigue. Conservative treatment for non-displaced and stress injuries. Long arm splint or cast for 3 weeks. And if it's displaced, they are going to have surgery. Side effects include stiffening, ulnar nerve injury, and symptomatic non-union. And I didn't explain non-union a minute ago, but if it's non-union, that means that the bones do not grow back together. Even if the bones are lined up, they still just have that fracture. Clavicle fracture is the most common birth injury. It can also be caused by the foosh, a fall on the outstretched hand, but it can be caused when the kid is in the birth canal. It can be caused by direct trauma, like a car accident, or maybe they're in sports. But 80% of clavicle fractures occur in the middle third of the bone. 15 in the distal third, and 5 in the proximal. Patients with a clavicle fracture typically hold their arm to the chest and experience pain when the shoulder moves. Obvious deformity often occurs, and it is occasionally missed in infants until the callus formation causes a visible bump. Without trauma, if a kid develops this, the injury can indicate the presence of bone cysts, and abuse should always be ruled out. Remember, it's kind of like I talked about last week. It's not up to us to report if there is or isn't abuse. It's up to us to report suspected abuse. That's where the forensics and the investigators determine if it's abuse or not. Not up to us. We just report any suspicions. Surgery is often required of a clavicle if open fracture is displaced more than 100% of the width, if they have tenting skin, which is the bone is pushing the skin outward, if there's fracture pieces, or any vascularity compromise. Although a figure 8 bandage was once a standard of care, this can displace the fracture, which complicates healing. Most ped fractures of this kind can be treated with a simple sling, which provides comfort and reminds others to proceed with caution. When the fracture is fully healed, the shoulder's full range of motion will be painless. Kids can generally return to pain-free activity by 4 weeks, but should not be allowed contact sports for at least 6 weeks. And remember, they may get a bump in the injured area from that callus, but it will shrink after full healing, but it may not completely disappear. Tibia fractures occur when the foot is twisted during a fall. It takes a lot of force to injure the tibia shaft, and this fracture is rarely displaced. A posterior lower leg splint is required for acute fracture because swelling occurs 24 to 48 hours post-injury. Non-displaced fractures require a long leg cast for 6 to 8 weeks. They are going to have weekly x-rays to monitor the position. And surgery is required if the break angulates more than 15 degrees. Toddler fractures occur with children younger than 2 ages who are learning to walk. No specific injury is noted most of the time. The kid just refuses to bear weight on the leg. And so you are going to have to examine the hip, thigh, the knee, the foot, just to rule out other causes of limping. You do need to consider abuse. And spiral fractures are common. Examine for soft tissue injury to the buttocks, back of legs, head, and neck. Transverse fractures of the midshaft are very suspicious for child abuse. These kids are treated with a long leg cast for 3 to 4 weeks. Weight bearing is tolerated and heals completely in 6 to 8 weeks. About 20% of kids with an injury have a fracture. And again, you can always do bilateral x-rays if you need to compare. Physical injuries are common and may have no x-ray findings, so treat it as a fracture. Femur fracture is a diaphyseal fracture, or more commonly affects males and children older than age 3. A femur fracture is highest in the summer months and typically caused by trauma such as falls, sports, and car accidents. When this injury occurs in toddlers, though, you really need to consider abuse, particularly if they have a spiral or corner fracture. Treatment aims to restore length, alignment, and rotation. They can have traction pre-surgery if the bone needs to be reduced, and they may need traction for quite some time. Casting, they're going to use to apply stabilizing forces to prevent further injury. They often use plate and screw fixation, open reduction, external fixation where the nails or pins to hold a fracture is on the outside of the skin. So they often will have IV lorazepam, which is Ativan, every 4 to 6 hours as needed, and this can help with the muscle spasms. Typically, muscle spasms will subside once a spica case has cast has been placed, and that picture on your screen is a spica cast. So it can be all the way down both legs, depending on what the injury is, but they do leave a toileting hole. So if it's an infant, you need to stuff a diaper up in there. Super important to keep this baby or toddler, if the child is 1 or 2 and not potty trained yet, but keep their skin dry. They're high risk for skin breakdown. And your older child, they're going to be able to toilet, just like that. The spica cast can, I talked about it having two full legs. It may just be a half a leg on one side. You're going to turn and reposition this kiddo every 2 to 4 hours while they're awake to prevent the pressure sores on their heels and sacrum. It's extremely important to do neurovascular checks every 2 hours for the first 24 hours post-op. You need to insert 2 fingers down along the abdomen of the cast to verify it's not too tight. They a lot of times will have oxycodone for pain. You need to monitor for any kind of respiratory depression. You need to monitor for side effects. They can get really constipated from all the medication. So, we're going to encourage them to drink clear fluids, encourage consumption of fresh fruits and vegetables, decreasing fried foods and constipation triggers such as cheese and milk until they're off of the pain meds. Remember, they're also decreased physical activity, which contributes to the constipation. So lots and lots of considerations. Which of the following is a type 3 fracture? Is it A, fracture passes transversely through the through the physis, separating from the epiphysis from the metaphysis, or B, fracture occurs at the epiphysis and exits through the epiphysis at the joint space? Fracture passes transversely through the epiphysis but exits through the metaphysis, or D, fracture extends upward through the epiphysis and out the metaphysis. Answer is B. In a type 3 fracture, the fracture crosses the physis and exits through the epiphysis at the joint space. Congenital is abnormalities, and this, is something that begins in utero and the child inherits, so they're born with it. Some disorders, though, can be unrecognized until the child reaches a later stage of growth and development. Clubfoot is a congenital abnormality. It can be a neurologic or idiopathic. Syndrome develops include deformity along with physical or development defects. Lots of different things here. Risk factors and incidents. They can have it unilateral or bilateral. Family history increases the incidence. Males are affected more often, actually about like a 2-to-1 ratio. It affects the entire lower extremity. The calf looks smaller and less ability to develop muscle strength than a typical lower extremity limb. The affected foot may be smaller, and it's typically fixed and rigid in a plantar fixed and pronated position. The Achilles tendon is tight or shortened. Non-surgical is to start the Ponzetti technique of serial casting in the first week of life. The casts are changed weekly for up to 12 weeks. After casting is complete, the correction is either with ankle foot or orthotics. If the serial casting doesn't work, they do often have to do surgery. and that's where they release the tight muscles or scar tissue formation. They can do tendon transfers. They can align bony bone fragments to reposition a deformity. Metatarsus adductus is a common foot deformity that involves a forefoot only, in which the patient presents with the foot turned inward. It's more common than females. In males and females, it's bilateral. They have adducted forefoot, normal hind foot, and prominent fifth metatarsal tuberosity. And I'm going to let you read in the book on internal femoral torsion because I need to stop the recording here. I will pick back up on the next slide in just a little bit. Hello. Next, we're going to be talking about genital verum, which is bow legs, or also known as a varus deformity. We hear this called bow-legged or bow legs a lot in kiddos, but it's a lower leg deformity that's seen in kids between 18 months and 3 years of age, although it can also affect adolescents. The typical clinical presentation is in-toeing. To the extent that a bowling ball can be placed between the legs. And remember, it is normal to have some leg bowing, but there are some features that differentiate genital verum from typical development. The normal progression of limb development is physiological bowing, then the lower legs straighten out, then physiological knock knees, then the legs again straighten out. And so by the time the kid is about 7 years of age or so, the limbs should be straight and not change to the remaining growth. Typical developmental bowing is typically symmetrical, does not worsen with growth, no lateral knee thrust, no X-ray changes in severity. It's present in infancy but resolves by the age of 2. And risk factors can be ambulation or independent weight bearing before the ages of 9 and 12 months. Heavy children, which are greater than 95th percentile in early years with early ambulation. In adolescent Blount's disease, the deformity occurs during the growth maturation, and those at risk are obesity or kids that are greater than the 95th percentile. Adolescent Blount's disease can cause premature closure of the lateral epiphysis in unilateral or bilateral tibias. Causes can be physiological with no known reason, can be tibial vera or Blount's disease, metabolic disorders such as vitamin D resistant, rickets, or hypophosphatemia. Remember, we said to draw a phosphate level in labs for musculoskeletal issues. Skeletal dysplasia, such as dwarfism. Focal fibrocartilaginous dysplasia, and that's benign dysplasia causing the upper leg to bow, or unilateral varus of the tibia, which is the most common location. It can also occur, though, in the humerus, the forearm, the phalanx, the femur. The epidemiology or demographics in infants or toddlers, the etiology and pathogenesis are often unknown, but associated conditions can be infantile tibia vera. So it's important to recognize the variation of infantile tibia vera because it can resolve without surgery. Physical abnormalities such as tumor, infection, or trauma. The treatment is going to be observation and should be treated by the age of 4 years, because after that it becomes much more hard to correct and carries an increased risk for damage to the growth plates. They do bracing in long leg orthosis, and that can be pretty miserable, and so compliance is often very difficult. Bracing will slow down the progression but does not reverse it. The surgical correction for adolescents Blount's disease is tibial derotational osteotomies. So patients are placed in either long leg cast for the first 4 to 6 weeks, followed by a short leg non-weight bearing cast for 6 to 12 weeks total, or in short leg non-weight bearing cast for 6 to 12 weeks. It's highly recommended to treat one leg at a time to allow for assisted ambulation and activities of daily living with at least 6 to 8 weeks in between. You really should educate and encourage lifestyle changes before the surgery to decrease the risk for complications such as bone non-union or DVTs. Education about healthy weight loss, healthy BMIs, and nutritional choices is extremely important. A lot of these kids can have altered self-image deficit because of teasing and bullying because they look differently. So a lot of these patients are emotionally scarred. Families can be argumentative because they often don't feel that obesity is due to the family eating choices and habits. Most kids who are overweight do have overweight family members, so helping the whole family is beneficial. But when you talk to the caregivers about the child being overweight, they can also take it very personal. But getting the whole family involved is extremely important. Your interdisciplinary team should be nutritionists, physical therapists, nursing staff, and social workers. Genome valgum, knock knees. Just a second, I want to turn on my heater here. I'm freezing. Knock knees is a valgus deformity, and so it's the opposite of genome verum. And affected children present with knee kissing and often run with an abnormal gait. It's often growth related and it's asymmetrical, such as after trauma or infection causing premature growth arrest. Metabolic disorders such as rickets or arthritis can cause it. Skeletal dysplasia, neuromuscular deformities such as cerebral palsy. Treatment can be non-surgical and surgical. Ages 2 through 10 are often treated with observation or orthosis. Although the later is controversial because children don't tend to like wearing braces. Surgery is indicated for kids age 11 to 13. Surgery, you can see medial physical stapling, which prevents the deformity by allowing the opposing side to catch up. Medial physical hemiepiphydosis, which stops the growth plate on the side of the deformity to allow the deformity to correct. And osteotomy, which is a wedge of bone removed to correct the deformity. The next abnormality is calcaneovalgus foot or valgus foot, and it's one of the most common causes of foot deformity due to packaging in utero. It's often confused with club foot, so just remember it is different. It's not considered problematic in terms of growth and development. And children and families are often concerned, though, that it may hinder sports performance. The condition usually resolves spontaneously between 2 and 6 months of age, although stretching exercises are indicated in rare causes. Clubfoot is often attributed to the following positions in utero, and that's where one foot is against the wall of the uterus, dorsiflexed, lateral tibial torsion, which is usually flexible. Treatment, the condition usually resolves itself once the infant is out of the enclosed wound and relaxation of the tight positioning occurs. Another abnormality, lateral tibial torsion, is often associated with the calcaneovalgus foot deformity. It presents as out-toeing in infants, but usually resolves at about 18 to 24 months of age after walking begins, and does not usually cause lifelong problems. In older kids, tibial osteotomy is done to derotate the limb into its correct neutral alignment. Hip dysplasia, which is the picture on this slide, as you can see on the left is normal hips and on the right is the hip dysplasia. It can be either congenital or caused by in utero positioning. It's also called developmental dislocating hips, and congenital dislocating hips. The etiology is often multifactorial, can be a combination of mechanical factors, physiological factors, postnatal positioning. The condition can be subtle and is often missed or misdiagnosed because initially infants are symptom-free. Pelvic x-rays after age 6 weeks assist with diagnoses. Dynamic ultrasound is used for diagnoses before 6 weeks of age. Risk factors that can be related to the development of hip dysplasia include being the first-born child. Female ratio, 6-to-1 is female. Up to 8-to-1, so up to 80% can be female. Left side is affected, associated with left anterior positioning in the utero, breech presentation, limited hip motion, petite mother with or without low amniotic fluid, multiple gestations, maternal hormones, family history, generalized ligament laxicity, neuromuscular disorders such as cerebral palsy, myelomeningocele, spina bifida, extension or adduction cradle boards, and it actually occurs more in kids born in winter. And there are some neuromuscular conditions that can cause gradual development of hip dysplasia. And this is children with neurological conditions such as cerebral palsy or myelodysplasia can also develop hip subluxation or dislocation. The spasticity in children with cerebral palsy overpowers the muscles that keep the femoral head located in the socket. Tone control is helpful, but patients may need more aggressive treatment options to slow down the progression. Surgical intervention is common before the hip dislocates in a growing child to prevent femoral head and acetabular deformities. Children with myodysplasia may develop disorder because of the inherent loss of muscle and nerve innervation. Children with spinal muscle atrophy are at a higher risk. However, there are some that will live sedentary or ambulatory lives without any problems. Clinical presentations are often limited hip abduction, asymmetrical thigh skin folds, absence of knee flexion, contractures, Barlow test, which measures the hip stability, along with the Ortolani test. The Ortolani test shows a dislocated hip, Galeazzi sign, which is an uneven knee height in the bent knee position. And infants must be calm to do these tests, because think about if your infant is stiff, they're not going to be able to be as the testing is not going to be as accurate. Treatment, Pavlik harness, like we showed on our other slide. If you remember, the Pavlik harness is a type of abduction brace. Safety measures include ensuring proper fit and checking toes for vigorous capillary refill and movement after application. Bryant's traction, and that's where the extremity is suspended, and you want to make sure and keep the weights free from the bed. They need to be free flowing. We need to prevent falls. We need to assist caregivers and family with positioning to decrease friction to skin and bony prominences. Sometimes these kids will be in a spica cast, and surgery may be required. This is the Pavlik harness. So as you can see, they're stuck in the abduction pose. Adduction, remember ADD is add to the midline, whereas abduction is apart. That's how I always remember it. ADD, adduction together, because you're adding to the midline. Abduction is apart. Legg-Calvé disease is a loss of blood supply to the femoral head. Most of the time we don't know the cause, but we do know it's more often in boys aged 2 to 9 years, and it can be painful. Most often, the most often sign of it is limping or inability to bear weight on the affected leg. It's often unilateral, 90%, bilateral, 10%. There is an increased risk with family history, and it's most common among Caucasians, Asians, and Alaska Natives. You're going to want to make sure and be culturally competent. You're going to want to be aware of the causative factors, and multiple theories exist. Some theories are we don't know the cause. Others know that there are thrombolytic components or trauma. The weird thing is geographical locations have a noted higher and lower incidence of cases. For instance, rates that are 4 times higher in Korea have consistently been noted. Excuse me, I said that wrong. Rates that are 4 times higher than Korea have consistently been noted in Great Britain. Clinical presentation is pain, groin pain, thigh, knee pain, increases with movement, decreases with rest. It's not similar to pain of internal hip rotation. They can have limpness, decreased range of motion, hip abduction, hip internal rotation. The next abnormality is avascular necrosis, and this is becoming more and more common. It results in blood loss to the femoral head of the femur caused by fracture or dislocation. Symptoms may not be evident for up to 2 years. Severity depends on the child's age of development. The younger the child is at time of diagnosis, the better the outcome. The femoral head is sometimes oddly shaped and ovoid with a widened femur neck shaft. And the AVN process occurs over approximately 1 to 4 years and has telltale signs of development and remodeling or rebuilding, which is your pre-necrosis, necrosis, and space revascularization. In your pre-necrosis, it's going to have an insult that causes a loss of blood supply. In the necrosis, the femoral head doesn't have blood supply. The femoral head, though, is structurally intact. It's asymptomatic. X-rays may be normal. The revascularization, which is typically a 1 to 4 year process, is new bone deposits, dead bone reabsorption. The femoral head is weak and susceptible to fracture. Bone healing, reossification occurs gradually, reabsorption stops, and the bone returns to normal strength. Then remodeling. The younger the age of development, the greater the potential for remodeling, and the child usually presents with limping plus or minus hip, thigh, and knee pain. The condition can wax or wane for months to years, and the goal is to keep the femoral head in the hip socket to maintain a good hip joint and decrease the risk for permanent deformity. Used to we would hear about avascular necrosis only being in alcohol abuse, but we've came to realize that there are many cases that are not caused by that. Treatment aims to eliminate hip irritation or pain, restore and maintain range of motion, prevent collapse of the capitofemoral epiphysis, which is also known as the proximal femur growth plate, attain a sphere femoral head, not ovoid, contain the femoral head in the rim of the acetabulum. Treatment modalities are traction, and it can be brines or bucks. You can have Petri casts that are changed every 6 to 12 weeks. And this cast extends from mid-chest to just above the knee. And remember, it's going to be like the spica cast. There is going to be an opening left for toileting. They can have surgery where the proximal femoral derotational osteotomy, and that's where opposing deformity to be in better alignment. Bracing is highly controversial. So they can have a lot of, again, self-image deficits with this. The next abnormality is a slipped capital femoral epiphysis, and that's a hip deformity of childhood and has a widespread epidemiology due to environmental and neuro factors. The following factors increase the incidence, which is adolescent onset at the time of growth spurts. Male, is 10 to 16 years of age. Females are, hit their growth spurts earlier, so it's 10 to 14. Most common among African Americans, incidence is 25 to 30% of cases. And a lot of the kids are obese or tall. They can have a developmental delay. Causative factors are idiopathic, which is the most common. You can see risk factors of obesity, juvenile hormonal changes, endocrine problems such as diabetes, radiation exposure, chemo. The clinical presentation of these kids are anterior thigh and knee pain, analytic gait, which is a limp that's adopted to avoid pain on weight-bearing structures. And so it's characterized by a really short stance phase, externally rotated lower leg, decreased range of motion in hips. Treatment is slipped capital femoral epiphysis, and it's treated with the use of crutches or wheelchair to protect activities for 6 to 8 weeks. The treatment goals are to stabilize the hip joint with open reduction, internal fixation, a surgical technique in which a femoral screw is used to hold the joint in place and support healing. We're going to promote healing, basically. We're going to avoid complications such as further injury to help the growth plate, DVTs and infection. We want to improve the hip function. The last abnormality on this slide is transient monoarticular synovitis. I can't speak. Synovitis, and it's the most common cause of acute onset short duration limping in children. This is due to intermittent inflammation at the hip joint. It's more common in males than females. Average onset is about 6 years, but it can range from 2 to 12 years. The cause is nonspecific, hip irritation or synovitis. It can be classified as allergic or inflammatory reaction, viral following an upper respiratory infection, result of a minor trauma. Clinical presentation, mild limp, low-grade fever, which is less than 100.4, anterior thigh or knee pain, irritable hip, which is a positive roll test, mild limb rotation, which is favored position is to hold the lower leg turned outward. You can see septic arthritis, you can see osteomyelitis, you can see leg calf Perthes disease. Diagnostic testing is a CBC and differential. Elevated erythrocyte sed rate, ESR. Negative arthrocentesis, which is a negative culture. They don't have crystals. Treatment is bed rest 7 to 10 days. And we don't do a lot of bed rest, but this is one that we do. Traction to hold the hip in a restful position to relieve fluid buildup. Bone scan to determine location of other sites of irritation, inflammation, or infection. And that's a lot of times in your kiddos that aren't old enough to describe the location of pain. Septic arthritis and osteomyelitis of the hip is most often caused by Staph aureus. Group A strep and strep pneumo can also cause it. And group B strep and gram negative are often causes of osteomyelitis in the neonatal period. They're managed very closely after hospital discharge, usually by pediatric orthopedics and infectious disease specialists both, until their lab levels have returned to normal and they have full restoration of pain-free range of motion. The length of antibiotic treatment, both IV and oral, depends on the severity and the types of organisms, and most kids will need yearly follow-ups after the treatment to make sure the hip joint and anatomical features develop correctly. Septic arthritis and osteomyelitis are considered orthopedic emergencies. Delay of treatment in either case can cause severe deformity and even death. Both are primarily seen in infants and can follow an illness by several weeks. Many patients initially present at the doctor's office with an ear infection or strep infection several weeks before the onset of osteomyelitis. You know, it's funny because so many people think that strep is not a big deal. Untreated strep is a very big deal. It can cause all kinds of things, as you've noticed that we've talked over the last few weeks. You're going to ask about a history of fever, runny nose, cough, or cold the last several weeks. Clinical presentation: irritable, refusing to eat, hip flexion contracture, abduction and externally rotated position of comfort, pain with hip range of motion, erythema, edema, minimal fever but may progressively get worse. The child will look sick or can look sick and may look septic, but they can't have a normal CBC. Clinical presentations: a limp. They may refuse to weight bear or walk. They may have a history of trauma, surgery, or infection. They may have a hip abnormality. They can be in a flexed or abducted position. They may be externally rotated. They may have a pain with hip rotation or range of motion, especially internal rotation hurts. They may be febrile and appear toxic. They can have positive leukocytosis, and the treatment of choice is to admit urgently to the hospital. They may need emergency surgery for an IND, and they may need a repeat IND every 1 to 3 days. They may have systemic antibiotic coverage, usually with a peripheral inserted central catheter for 3 to 12 weeks, depending on the organism growth, followed by oral therapy. And again, this all depends on the organism. A lot of times we use Cipro, Siloxane, or Zyvox. We can use Bactrim. Prognosis is determined by several factors such as age of onset, site of initial infection, delay of diagnosis, and organisms present. Scoliosis. This is actually quite common. It's a term for the curvature of the spine that deviates from normal spine alignment. Scoliosis is predominantly idiopathic in origin, which means we don't really know why. There are some theories that think it may be related to intrauterine molding, as some of the other disorders that occur, such as like torticollis or hip dysplasia. Congenital scoliosis, that is where they get scoliosis before the age of 6 months. It can be genetic or caused by intrauterine or external uterine forces applied to the infants during growth and development. You always want to make sure they're having a clinical evaluation at infant checkups by a healthcare professional. X-rays will determine the severity of the curvature, and a complete neuroexamination is crucial to rule out other deformities. Severe cases are evaluated with MRI scans, especially left-sided curves. And so why do you think a left-sided curve would be more serious? Well, if you think about it, your heart is on the left side. So if your curve is going over, is it compressing that heart? The curvature is measured from thoracic to lumbar curvature and lumbar to sacral curvature using the Cobb method of angles, usually in an S-shaped curve. Clinical presentation: congenital scoliosis or idiopathic scoliosis are very rare, less than 1% of all scoliosis cases, and it is more common in Europe than in the US. Girls with right-sided infantile scoliosis tend to have a worse prognosis. Treatment is bracing to hold the positional curvature while the child matures. Casting, which is a riser cast, and that holds the deformity from progressing. Surgical instrumentation, which are growing rods, but those have to be changed every 6 months. Definitive spinal fusion. Juvenile scoliosis, that is a scoliosis that is a spinal curvature before the age of 10 years. It's more common than infantile scoliosis, but less common than in adolescence. It's about 10 to 15% of all idiopathic cases. Tends to be right-sided. But children with left-sided curves far better than those with right-sided ones because the right-sided tend to be more severe. And treatment is not as painful. However, the left-sided can be more problematic because of the heart. Clinical presentation. You're going to have them bend forward, and you're going to see, you're going to stand at the back of them and see if their shoulder blades are even, if their hips are even. Even a mild case, when they're bent forward, the shoulder, one shoulder may be uneven or one hip could be uneven. Decreased range of motion of upper trunk is another signs and symptoms, and x-rays typically reveal more than a 10% curve that is typically a S or C shaped. Treatment are based upon the time of the diagnosis, age of the child, and likelihood of progression. Minor curves that are 15 to 25%, you're just going to observe. You're going to brace for moderate curves that are over 25 degrees with the TLSO bracing, and a riser cast for rigid curves. And these riser casts are changed every 6 to 12 weeks, followed by bracing. Surgical intervention, like we said, is the rods, but they do have to be changed about every 6 months. Adolescence idiopathic scoliosis is age 9 years to adulthood. This is about 80% of the cases. More common among girls than boys. It's usually characterized by a C or S-shaped lateral curve to the left or right. It often goes undetected because it rarely causes pain or rarely changes their activity level. For curves between 25 and 45 degrees in kids who are still growing, braces can forestall the curve progression through puberty. Surgery is usually recommended for curves more than about 50 degrees. Surgery includes a back incision from below the neck to just above the buttocks, so it's a huge surgery. Post-op recovery includes spinal fusion care path. So you're going to be concerned about daily activity. You're going to have good recovery objectives. And patients may need oxygen for 24 hours post-op, as well as a urinary catheter. These kids are going to be turned and repositioned every 2 to 4 hours. Home care post-operatively education is going to be no bending, twisting, or sudden motions for up to 3 months. No contact sports, no gym classes for up to 5 months. And exercise will be daily walking at least 3 times a day. They need to avoid sitting for long periods. Remember, you don't want them to get a DVT or pulmonary emboli. You're going to encourage spirometry to keep the lungs inflated. You're going to include education on prevention of ileus. So, maintaining I&O, turning in bed, encouraging fluids. You're going to monitor for D-cube ulcer formation. You're going to monitor for constipation from the opioids. So you're going to provide a high fiber diet, increase water, avoid foods that constipate. Patients may need a suppository or fleece enema to improve bowel evacuation if constipated. Juvenile idiopathic arthritis is a common diagnosis for pain and inflammation in multiple joints that can occur early as 2 years of age. Caregivers typically seek medical help when the child presents with on and off joint pain in several joints over a period of months. And although some cases are just one joint, you can have multiple joints. And they typically affect the knees, the ankles, and hips first, and it is usually bilateral. It is the most common chronic rheumatic illness and can cause significant short and long-term disability. It's regarded as a complex genetic trait with multiple genes causing inflammation and immune response. Diagnostic tests are going to be CBC with differential, ANA, rheumatoid factor, HLA, the C3s, which are the complement components, the C4s, Epstein-Barr virus, and SED rate, a CRP. These kiddos should be monitored for nutritional deficits, uveitis, which is inflammation of the iris of the eye, growth disturbances, including delayed puberty, psychological concerns due to chronicity of the disease and active disease causing functional limitations. Treatment goals include controlling pain and inflammation. These kiddos are often on naproxen or Aleve, and methotrexate, which is your Trexall or Rumitrex. Take medications with food. Stop if it causes nausea, vomiting, rash, or diarrhea. You're going to try to preserve their function. You're going to try to promote normal growth and development and promote their psychological well-being. Treatment modalities, physical therapy, occupational therapy. You may see some splints, arthroplasty, NSAIDs, glucocorticoids, disease-modifying anti-rheumatic agents, methotrexate, I'm not going to say this right, leflunomide, biological agents, which is a lot of times you see Humira for polyarthritic, Orencia, Enbrel, Actrama. So lots and lots of different agents. You can also see some stem cell transplantation. If they're adolescents, you want to make sure that they're using a backup birth control. Don't take the chance that they're not sexually active, because if they get pregnant while taking some of these medicines, it can be really bad. Osteogenesis imperfecta. Don't you like my little guy there I found? This is also called brittle bone disease. It is an inherited disorder resulting from a collagen defect or dominant gene mutation. Some kids diagnosed have no known heritage linkage. It's just like it sounds, brittle bones. They have fractures of the shoulders, humerus, clavicle, or femur, commonly occurring at birth via the birth canal. Little external trauma is present. Infants can be sent home and later present in the ER with inability to move an upper extremity or swollen and painful lower extremity. On TikTok, there is a couple of twins. I'm trying to think of what their names are. I highly encourage you to look them up and follow them. The mom is very open about their struggles with OI, and it's very sad because like their arm, I mean, is obviously really deformed. See if I can tell you the name of it really, really quickly. But it really shows what these kids go through. It's really sad. Okay, their names are Mia, and it's called Our Little M&Ms. So Our Little M&Ms, or you can search Osteogenesis imperfecta, but very, very open and non-biased, and I really highly recommend it. The disorder is classified into types 1 through 4, mild to severe. The diagnosis can sometimes be made later in infancy or even at toddler in a mild case. They can have severe OI. They can have multiple fractures of the long bones of the body multiple times, often in short times. And sometimes these kids will be diagnosed with abuse. And then once they finally start looking into it, there was no abuse. They just have this disorder. The infant can also present with blue sclera, which is a bluish tint of the eyes, but not always. Lab tests is a SDS page, which is sodium doxycyl sulfate polyacromide gel electrophoresis. So SDS page, cyanogen bromide mapping, thermal stability studies, and sometimes the diagnosis is detectable in utero by ultrasound when they see bowing or unusual shortness of the long bones. The more severe the type, the more identifiable it is in clinical presentation. And remember, if you're seeing this patient and you don't know if it's abuse or OI, remember, it's kind of my little hot topic. It's not up to you to figure it out. It's up to you to report suspicions. Let the forensics do that. I will tell you, as a forensic nurse practitioner, I constantly, when these cases come in, we do always roll out the medical causes. And in all honesty, I actually diagnose more non-abuse than I do abuse, because a lot of these kids will have some kind of a disorder that can cause things that mimic abuse. You're going to ask you're going to educate the family with assisting with holding, feeding, changing to decrease the incident. You're not going to take a blood pressure if it has caused an upper arm fracture in the past. You're going to place signs over the bed that remind staff to use caution and care while moving, because even just moving them can cause fractures. Nursing interventions, besides what I just said, they also need to use precautions such as phlebotomy, blood drawing, fall prevention education. And there's lots and lots of different resources online at the OI Foundation that I highly recommend. Sports-related injuries, about 30 million kids last year participated in some sort of organized sports that are age 14 and older. That are age 14 and younger. We see out of those 30 million, we see 3.5 million sports-related injuries. Most common, football, soccer, and basketball. And the injuries have increased because of the availability of indoor arenas for like soccer and baseball. Some of the most common injuries are sprains, strains, dislocations, subluxations, tears, fractures, hematomas, overuse injuries like little leaguer's elbow, tennis elbow, tendonitis, growth plate fractures. Mechanism of injury is often rolling the ankle into inversion with an ankle sprain. That's what happens. And then treatment modalities can be splints, casts, walking boot. They may have a lace-up ankle brace depending on the severity. You can do strengthening with physical therapy. Dislocations and subluxations, that's where they're hyperextended or pulling, such as a varus or valgus. Pain, swelling. Nursemaid's elbow is extremely common of the toddler population, and that's because people go to lift these kids up by their arms, so it dislocates the elbow. So you need to educate them not to do that. Also, if they have Ehlers-Danlos syndrome, this causes laxity due to collagen deficits and may affect adolescents. Treatment usually requires sedation in the ER so that it can be relocated. Prevention, if this is a reoccurring thing, you can also do surgical intervention. Tears and contusions, most often usually due to the foot planted and the body continues moving forward, or some type of twisting injury, and usually they hear pop and they have instant pain and swelling. You can do x-rays and MRIs, and as you guys know, this is most often the knees, such as your ACL, MCL. They may need crutches or braces. Prevention includes education on proper body mechanics and weight training during sports seasons. Overuse injuries, proper coaching. Always stretch before playing or exercising, cool down afterwards. Wear shoes and equipment that fit properly. Know your body's limits. Build up to exercise gradually. Do a total body workout consisting of cardiovascular, strength training, and flexibility exercises. Always get a physical examination before they start playing competitive sports. Don't play if you're tired or in pain. So if it hurts, don't do it. So our last question, what is the most common bacterial pathogen causing osteomyelitis in kids? Do you remember this? Group A, strep, strep pneumo, Kingula, or Staph aureus? The answer is D. Staph aureus is the most common bacterial pathogen causing osteomyelitis. Group A, strep, strep pneumo, and Kingula are the next most common. So, long lecture. It's been an hour and 20 minutes for both pieces together. I hope this helps make sense. Don't hesitate to reach out to me if you have any questions. Thank you. Have a great day.